before we go into A, how chemotherapy affects fertility, B, what we do to preserve fertility, we need to understand the ovary. We're primarily talking about female fertility preservation here. But let's refresh our memory how ovary works. First of all, women are born with a set number of follicles, primordial follicles. These were laid down in utero. So a 28-week fetus has all the follicles, primordial follicles, she could have. And these follicles sit around, and through an unknown process through life, through reproductive life, they would initiate growth. And this would take about 3 months. So the follicle you ovulate today started growing more than 3 months ago. And this process of growth is not dependent on hormones. That's why putting ovaries to sleep, giving them hormonal suppression, etc. doesn't help to protect this process. Otherwise, we would just take, for example, GNH analogs and never go into menopause. This doesn't happen, right? Once the follicle starts growing, it goes through all these stages. It does not produce hormones until about the last week, or until we can see it on ultrasound. So the hormonally active part is only about the last week. Now, if the chemotherapy agent damages these developing follicles, but not the reserve follicles, that's not a big deal. Then we would start making more follicles from the reserve. What you would see is about maybe 3 to 6 months of cessation of periods. But eventually this reserve would help us restore the follicle development. But if a drug affects the primordial follicle reserve, then that would have an everlasting effect. This doesn't have to be chemotherapy. When you do surgery, when you do, let's say, cystectomy, you took the dermoid and you took a piece of the ovary. Now the patient has lost a significant cache of her ovarian reserve, or you removed one ovary because of surgery. It's the same concept. So not all cancer drugs are the same. Certain drugs, alkylating agents like cyclophosphamide, topoisomerase inhibitors, and this data is from our lab actually, such as doxorubicin, they do attack these follicles. So it damages the reserve. But antimetabolites, for example, you give methotrexate for your ectopic pregnancies, right? That doesn't seem to affect these follicles. It may affect these because these antimetabolites are very active on rapidly growing cells. So these follicles are growing, so they'll be sensitive. But not a big deal. These follicles come back and produce more. So that's why we say that they're not equal. Also, in terms of measuring ovarian reserve, we have a better marker now called anti-Mullerian hormone, because it's directly produced from follicles, and it's produced from relatively early stage follicles. For example, we have inhibin B is produced from these later stage follicles, so the information about these early stages are coming from a remote location. But AMH is produced from these early stage follicles, and you will see me referring to anti-Mullerian hormone, which is also not a stage dependent. Even though there's slight variability in the cycle, anti-Mullerian hormone could be liberally drawn throughout the cycle. So this group of people that I have the fortune of working with, what they did was they took cadavers from newborn all the way up to menopausal age, and they counted their primordial follicles. And they come up with this. Women who are at birth, females, have about 1 million eggs. And throughout life, these numbers go down. And when you hit about around 37, 38, there's a sharper decline. There's a sharper decline. And actually, this is the age where lots of indices change. Fertility rates go down, miscarriage rates go up. And that's kind of the magic point, the critical point in reproduction. So women are born with a set number of eggs. So let's look at this. This is from one study that we did. We looked at biopsies from women who had received chemotherapy, ovarian biopsies, and who did not. And compare their follicle numbers, primordial follicle numbers. So the ones in circle are no chemotherapy control, and the ones in triangle are chemotherapy. So when you look at their follicle density, an average patient who received chemotherapy, who was about 22, has the same follicle density as somebody who did not receive chemotherapy and 10 years older. So that means overall chemotherapy is advancing ovarian age by 10 years. So for our oncologist colleagues, you have patients who receive chemotherapy and then it looked like they retained or they resumed their menses. We sometimes think that, oh, they're okay, they're not harmed by this. No, they were, but they lost about 10 years of their reproductive life. If you are close enough to the menopausal age, it may put you in menopause, but if you're young, it just makes you closer to menopause. And this is what happens in children as well. So anybody, newborn or adult receiving chemotherapy of some of these alkylating agents and topoisomerase inhibitors, you're propelling them along the curve of aging. So it's sort of an accelerated aging of ovaries.